Welcome to the pre-class module on infectious endocarditis. My name is Andy Hale and I'm an ID fellow at the Beth Israel Deaconess Medical Center. I'm really excited to take you through this devastating but fascinating disease. First, let's go over what infectious endocarditis is. It's an infection of one or more of the heart's four valves that causes a bulky and friable vegetation. It's an important and very serious infection affecting thousands of patients annually in the United States with high rates of morbidity and mortality. It can present acutely over days to weeks or subacutely over weeks to months, with a wide variety of clinical manifestations related to diverse embolic, immunologic, and infectious complications. It kind of does it all, so diagnosing endocarditis requires an astute clinician with excellent physical exam skills and in-depth knowledge of the pathophysiology. Here's the outline of what we'll talk about today. We'll go over the pathophysiology and immune response, microbiology, the physical exam findings, diagnosis, complications, and the treatment of infectious endocarditis. First, let's talk about the pathophys and the immune response. Look, the heart valves have to be really tough. They see high pressures and are constantly in motion. Thus, normal heart valves are naturally resistant to clot and infection. That's because they're covered in endothelial cells that prevent platelet aggregation. For infection to set up on a heart valve, the valve's outer surface, composed of endothelial cells, needs to be damaged first. This will expose subendothelial collagen in the basement membrane. Let's have some fun to make this visual. Here's a schematic of the heart's four valves: the tricuspid, the pulmonic, the mitral, and the aortic. In blue here is a representation of normal valve surface. If some injury occurs, then the normal protective endothelial cells can be scraped off. Now if we zoom in closer, we see exposed collagen, represented as the purple strands. The platelet, previously happily bouncing off the healthy endothelium, is now exposed to the subendothelial collagen. Let's zoom in even more to look at this interaction and how it causes platelet activation and thus vegetation formation. First, the exposed subendothelial collagen, represented as the purple arrow in the bottom left, binds to the platelet's GP6 receptor. This causes platelet activation, which results in a shape change. Instead of being ovoid, the platelet puts out podocytes or projections, which makes it easier to link with other platelets. Activation also causes formation of the GP2B3A receptor on the platelet surface. This binds to fibrinogen, which binds to other platelets' GP2B3A receptor, and thus links platelets together, causing aggregation. But the party isn't over yet. Activation also causes the release of so-called dense granules. These release ADP, which is just one phosphate short of our old friend ATP, which, acting via the ADP receptor, causes further platelet activation. This causes an increase in thromboxane A2 synthase, which makes thromboxane. Thromboxane is an important cause of platelet activation and aggregation. These steps are complicated, but are worth understanding because this is the mechanism behind not just vegetation formation in infectious endocarditis, but anything that causes platelet activation, from deep vein thrombosis to myocardial infarction. So it's no surprise that there are lots of drugs that target different parts of this pathway. GP2B3 inhibitors like integralin are used in the cath lab for myocardial infarctions. ADP agonists like clopidogrel, better known as Plavix, are other important anticoagulants. And of course, thromboxane inhibition is the mechanism of action of aspirin. So this stuff is really important. Now let's go back to our exposed endothelial surface. The platelet touches down and is activated. This results in further platelet aggregation, and the platelet clump grows and grows. Now there are two things that can happen. First, if there is normal healing, there will be fibrosis and a scar left over. Again, normally platelet activation is part of the normal healing process. It's not a bad thing. However, if there happens to be bacteremia or bacteria in the bloodstream, then the platelet plug can be seeded. And a seeded vegetation can grow and grow and grow. This is how you get a huge vegetation in infectious endocarditis. These vegetations can get truly huge, as seen schematically here. Why? Because the bacteria contribute directly to vegetation proliferation. Not only does their growth increase the size of vegetation, but some of them have virulence factors that directly cause platelet activation and aggregation. For example, Staph aureus has the virulence factor coagulase, which leads to more fibrin formation, and as we saw in the platelet mechanism slide, more fibrin means more platelet clumping. Additionally, Staph aureus has virulence factors that can directly activate tissue factor, which turns on the extrinsic pathway of the clotting cascade. So it's important to recognize that bacteria that cause endocarditis have important procoagulant effects. Here's what the devastating result of all this pathophysiology can be. Here we see a massive tricuspid valve vegetation that measured 3.5 centimeters. This thing was really huge and unfortunately killed this 26-year-old woman who had it. It shows that endocarditis is a bad player. Now coming back to that initial injury, we haven't talked about what actually causes it in the first place. Okay, here are the causes of injury to the heart valves. First is intrinsic injury to the valves. This is from things like congenital heart disease, prior episodes of endocarditis, rheumatic heart disease, or states with increased turbulent flow, things like aortic stenosis or congenital bicuspid valve. Extrinsic injury to the valve also predisposes to infectious endocarditis. This is from things like intravenous drug use. IV drugs have tons of contaminants that can directly scrape the heart valves. And the last is prosthetic valves and people who've had valve replacements. The foreign material is a great landing zone for bacteria circulating in the bloodstream. Now it's important to say that some bacteria cause endocarditis more frequently because they directly contribute to valve damage. For instance, Staph aureus secretes enzymes that can directly damage heart valves. These are things like hyaluronidase, which breaks down proteoglycans in connective tissue. And also things like proteases that directly destroy valve tissues. Now let's talk about the body's immunologic response to endocarditis because it's such an important part of the pathophysiology and explains a lot of exam findings. The vegetation is highly inflammatory. All manner of acute phase reactants are going to be high, things like the white blood cell count, the erythrocyte sedimentation rate, and C-reactive protein. The immune system is highly activated. Rheumatoid factor will often be elevated. Now you might think that you'd only see rheumatoid factor in rheumatoid arthritis, but that's not right. It's actually just a nonspecific immunoglobulin seen in certain highly inflammatory states, usually rheumatoid arthritis, but frequently endocarditis as well. Lastly, there's a polyclonal immunoglobulin population which create immune complexes that deposit throughout the body. In that way, endocarditis is not unlike a vasculitis at the microvasculature level. Immune complex deposition will cause things like osmodes in glomerulonephritis. Let's go through that pathophysiology a little more. It all starts with an antigen, and there's plenty of antigens in endocarditis because that vegetation is so full of bacteria. Then, the antigen causes immune complexes with the polyclonal immunoglobulins that are also created, and those immune complexes will deposit in small vessels. There, neutrophils and complement will be activated, which directly damages the tissues. So in this way, endocarditis is not unlike a small vessel vasculitis. Let's do a few questions to make sure you get the concepts. Here's one. A 46-year-old man with history of intravenous drug use presents with fever and is found to have infectious endocarditis. He states that the heroin he uses is not always pure. What cardiac valve do you think he is most likely to have an infectious endocarditis vegetation on? Why that one? I'll pause here for a few seconds, but why don't you pause the video and think of your answer? The answer is the tricuspid valve. Intravenous drug users have a higher incidence of tricuspid valve involvement. That's from impurities within the drugs that directly damage the valves, but are mostly filtered out by the lungs so don't damage the left-sided valves as much. These are things like talc. When the heroin user injects the drugs, plus the impurities like the talc, it goes through the veins, to the vena cava, to the right atrium, and then the first thing it touches in the heart is the tricuspid valve. That's why we see tricuspid valve involvement more often in IV drug users. Another question. Our patient is now found to have evidence of glomerulonephritis. Does this mean he must have left-sided endocarditis, meaning on the mitral aortic valves? Why or why not? Again, pause the video for a moment to think of your answer. No, it could be right or left-sided infectious endocarditis. Immune complexes can get through the pulmonary circulation and deposit systemically. So even though it's right-sided endocarditis on his tricuspid valve, you can still see immune complex deposition. Last question before we move on to the next topic. What would you expect the effect of aspirin to be on endocarditis vegetation size? Pause here and think about that. You'd expect aspirin to decrease the size of vegetations or prevent enlargement of vegetations by decreasing platelet activation and aggregation via inhibition of thromboxane. This was actually looked at in large clinical trials. Unfortunately, it didn't really shrink the vegetations that much, and it did increase the risk of hemorrhagic stroke, so we don't do this in clinical practice. Awesome! We got through the pathophysiology and the immune response to endocarditis. That was definitely the hard part. Next, we'll talk about microbiology, and which bugs are involved. Let's talk about the microbiology of infectious endocarditis. There's just a few common sources. The first is bacteria from the mouth, things like Streptococcus viridans. Also bacteria from the skin, things like Staphylococcus aureus, which is the most common cause, and other types of staph, like Staph epidermidis and other coagulase-negative staph species. The GI tract is another important source of bacteria that cause endocarditis, from species like Streptococcus bovis, with its association with colon cancer, and Enterococcus species. Here's a pie graph showing the frequency of different bacteria causing endocarditis. As you see, Staph aureus is by far the most common cause, causing almost a third of cases, followed by Strep viridans, Enterococcus, other types of staph, other types of strep. The Hay-Sec group, which we'll talk about in a bit, rarely gram-negatives that are not Hay-Sec, and fungi are a rare cause as well. The Hay-Sec group are 5 species of rare gram-negative rods that cause infectious endocarditis. They have these crazy names like Haemophilus afrophilus and Actinobacillus actinomycometans. Say that 5 times fast and I'll buy you a coffee. It's not worth memorizing the specific names, but if you ever go into infectious disease, man do the attendings love to ask you about this stuff. Here is a visual representation of the bacteria that cause infectious endocarditis and the frequency at different ages. You can see that the incidence goes up towards the late 70s, and that's because of age-related damage to the valves, which gets back to the pathophysiology we already talked about. Okay, so let's put together the pathophysiology and the microbiology to ask you guys this question. Which of the following is not a significant risk factor for endocarditis? Congenital valve disease, intravenous heroin use, recent dental cleaning, prosthetic heart valve, infectious endocarditis 5 years ago, rheumatic heart disease as a child, pneumonia in the last 30 days, or a recent colonoscopy. Pause the video here and think about your answer. The answer is G, pneumonia in the last 30 days. That is not a specific risk factor. Everything else either causes damage to the valve or would cause transient bacteremia, either from mouth flora in the case of the recent dental cleaning or from GI flora in the case of the colonoscopy. Great, that's the basics of the microbiology. Now let's get into the physical exam findings. There are several classic exam findings that are seen in infectious endocarditis that are really going to put your physical exam skills to the test. These result from a combination of direct valve damage, vegetation break-off and embolization, and immune complex deposition. The first broad category are new heart murmurs or worsening of old murmurs. That's because the infection tends to destroy the valve over time, so the valve becomes insufficient and it starts to regurgitate. If a patient had infectious endocarditis of the aortic valve, what would you actually expect to hear on heart auscultation? Would it be a crescendo-decrescendo systolic murmur, a mid-systolic click? What do you think? The answer is that you would expect to hear aortic regurgitation, which is a diastolic rumble, best heard at the left third intercostal space. If you forget what that sounds like or haven't heard it before, pause the video, go to this link, there's a great example of what this sounds like. Note that the destruction of a valve has more impact on the hemodynamics and turbulent flow, which again is the cause of a murmur, when the valve is supposed to be shut and not allowing any backflow during diastole than when it's open during systole. That's why destruction causes a diastolic rumble. Alright, the next broad category of physical exam findings are embolic phenomena, things like splinter hemorrhages, Janeway lesions, and Roth spots. Let's go through these one at a time. Splinter hemorrhages are microemboli to the nail bed. Basically, you get a small piece of the vegetation that flicks off and embolizes to the capillaries in the nail bed, creating a hemorrhage which looks like a splinter under the nail. So when you have a patient and you suspect infectious endocarditis, always look at all the nails on both the hands and the feet. The next physical exam finding from embolic phenomena are Janeway lesions. These are erythematous, non-tender, non-blanching macules on the palms and the soles. These are really in the meat of the hands, and again, they're non-tender. And remember that a macule means they're not raised. These are flat lesions. The next embolic phenomena are Roth spots, which you need to do a fundoscopic exam to see. These are retinal hemorrhages with pale white centers. Don't confuse these with conjunctival hemorrhage, which you can also see in infectious endocarditis, but that's just a gross finding, whereas these, again, are on fundoscopic exam. Alright, we've talked about exam findings from the destruction to the valve, from embolic phenomena, and the last broad group are findings from immune complex deposition, things like Osler nodes and splenomegaly. Osler nodes are tender erythematous nodules on the fingertips. Differentiate these from Janeway lesions, which are not painful. These are nodes, which are raised, whereas Janeway lesions are macules, which are flat. Also, these are on the fingertips, whereas Janeway lesions are in the pulp of the finger pads. Hold your hand out like you're cupping a ball, then turn your hand over and pretend Dr. Osler himself is grabbing your hand and tapping it on a hot stove. Your fingertips are painful. Damn you, Dr. Osler! All this immune complex deposition can cause splenomegaly, sometimes massively. This is the liver and the spleen of a 26-year-old woman who died of infectious endocarditis, and you can see the splenomegaly is truly huge. Compare that to this representation of the approximate normal size of a spleen. Hers is really gigantic. You're definitely going to be able to feel this on palpation in the left upper quadrant on physical exam. Here's a question for you. Osler nodes can be seen in both left and right-sided endocarditis, but splinter hemorrhages tend to be seen only in left-sided endocarditis. What do you think is the best explanation for this? Pause here and think about that. It all comes down to the underlying pathophysiology behind Osler nodes and splinter hemorrhages. Osler nodes are immune complex mediated, whereas splinter hemorrhages are embolic related. Thus, unless the patient has a patent foramen ovale, you won't see splinter hemorrhages with right-sided endocarditis. But Osler nodes are from immune complexes, and those can pass through the pulmonary circulation, so you could see Osler nodes with right or left-sided endocarditis. Great, we got through physical exam findings. Let's move on to how we actually diagnose endocarditis. We basically take everything we've talked about, the clinical, physical exam, imaging, and microbiologic findings, and put them together to see if a patient does or doesn't have endocarditis. These are combined into the modified Duke criteria, which are going to give us an objective way to make the diagnosis. The modified Duke criteria have 2 major and 5 minor points. The first major criteria is that you need 2 separate positive blood cultures from typical endocarditis organisms, things like staph, strep, Enococcus, or Hayseck bacteria. The second major criteria is that the heart valves need to be involved. That can either be from a vegetation or valve abscess seen on echocardiography, or a new valvular regurgitation, which either you hear by auscultation or see on echocardiography. The first minor criteria is a predisposing condition, either the use of intravenous drugs, a congenital valve defect, a history of rheumatic heart disease, or anything else we talked about in the pathophysiology section. The second minor criteria is a fever. The third is evidence of embolic phenomena, splinter hemorrhages, Janeway lesions, Roth spots, or any arterial emboli. The fourth is any immunologic phenomena, things like Osler nodes, positive rheumatoid factor, or glomerulonephritis. And the last minor criteria is a positive blood culture from an organism not typical of causing an endocarditis, like other gram-negatives besides the Hayseck group, fungi, or other bacteria. To make the diagnosis of infectious endocarditis, you need 2 major, or 1 major and 3 minor, or all 5 minor criteria. So it really does take a combination of lab, physical exam, and imaging findings. Here's a question. A 78-year-old woman with advanced lung adenocarcinoma has an obvious aortic valve vegetation on echocardiography. She is not known to have prior heart disease. She has no positive blood cultures, no fever, and no physical exam findings that suggest endocarditis. Is this infectious endocarditis? And if not, what else could it be? Pause here and think about that for a few seconds. No, she does not meet the modified Duke criteria, thus at this point we cannot diagnose infectious endocarditis. It goes to show that a vegetation alone is not enough to make the diagnosis. So what else could this be? Well, there's a bunch of things that can cause a valvular mass, including prior bacterial endocarditis that resolved but with a persistent sterile vegetation. Just because you treat the endocarditis doesn't always mean the vegetation goes away. Sometimes it does persist. Also, it could be a sterile valve thrombosis in hypercoagulable states. It could be a valve neoplasm like a fibroelastoma. Rarely, some cancers will metastasize to heart valves. There's also an entity called merantic endocarditis, where certain inflammatory conditions like lupus or adenocarcinomas cause sterile vegetations to form on valves. None of these are infectious endocarditis, but goes to show that there can be many things that cause a mass on heart valves. Awesome, we got through the diagnosis. Let's go into the complications of endocarditis. There are a lot of them. The first is that the patient can just be frankly septic. And then there are all sorts of embolic events that can occur as vegetation breaks off. If we're talking about left-sided endocarditis on the aortic or mitral valve, then one can get septic emboli systemically. You can get strokes, myocardial infarction, splenic infarction, renal infarction, any sort of infarction. If the patient has right-sided endocarditis on the tricuspid or pulmonic valve, then the emboli will go to the lungs. This causes pulmonary septic emboli. Of course, if a patent foramen ovale is present, you can get systemic emboli as well. Other complications of endocarditis include local destruction. The valves can be completely chewed up, and that can cause severe regurgitation and heart failure. Or the infection can cause an abscess at the root of the valve and cause conduction block. We'll talk more about that in a moment. Let's go through a few pictures. Here are imaging and pathology of a vegetation that caused a large splenic infarct. This would probably cause severe left upper quadrant abdominal pain. Here are the pathology findings of fatal pulmonary septic emboli in a young woman who had tricuspid endocarditis. The arrows point to the emboli themselves, and the red areas around them show the pulmonary hemorrhage that occurred as a result. Paravalvular abscesses can also cause heart block, as seen in the rhythm tracing here. Here's why. The valves, especially the aortic valve, is in very close proximity to the conduction system. If a paravalvular abscess forms, it can compress the conduction fibers in the bundle of His and cause heart block that can range from 1st degree to 3rd degree. One of the more feared complications of endocarditis is an epidural abscess. This is where the infection is spread to the epidural space next to the spinal cord. That causes an abscess, as shown here by the red arrow, which compresses the spinal cord here in the blue arrow, which can cause paralysis very quickly. Another feared but quite common complication of endocarditis is septic emboli to the brain causing stroke. Here, pieces of vegetation embolize off to the brain. The vegetation tends to break up as it embolizes, showering the brain with emboli, as seen on the image to the right. Clinically significant stroke will affect 20 to 35% of patients with left-sided endocarditis, though if you do an MRI on all patients with left-sided disease, up to 80% of them will have some evidence of microemboli on imaging. It goes to show how fragile the vegetation is and how dangerous endocarditis can be. Alright, the last section to talk about is how we treat this disease. Intravenous antibiotics are the mainstay of treatment. Typically, you need at least 6 weeks of treatment, and the antibiotics should be directed at the causative pathogen. One also has to consider the need for surgery in every case. But surgery is no small matter, as typically involves open heart surgery for valve replacement. So who needs surgery? Well, if the valve is too damaged to function, i.e. if the patient has severe heart failure symptoms, they're going to need a valve replacement. Or if the vegetation is very large, typically larger than 1 centimeter, it's another indication for surgery. Additionally, if there have already been serious embolic events and there's more vegetation that could break off, surgery could be indicated to prevent further damage. And lastly, some pathogens are really hard to treat, like Candida, fungal endocarditis, and sometimes surgery is needed there as well. Here's a question. A 27-year-old female is admitted to the hospital with infectious endocarditis of the aortic valve. On EKG, you notice that she has Wenckebach phenomena, meaning second-degree heart block. Question. Is her infection likely to respond to 6 weeks of antibiotics alone? Why or why not? If not, what else would you recommend? Pause the video and think about that for a few seconds. No, antibiotics are unlikely to be enough. She has evidence of heart block. This implies she has a paravalvular abscess as a complication of her aortic valve endocarditis, which is compressing her His-Purkinje system. Antibiotics have trouble penetrating abscesses. Thus, just like any other abscess, she's going to need surgery to drain it. In conclusion, infectious endocarditis is an infection of one or more of the heart's 4 valves that can cause a bulky and friable vegetation. It's an important and very serious infection which affects thousands of patients in the United States every year and has a high rate of morbidity and mortality. It can present acutely over days to weeks or subacutely over weeks to months, with a wide variety of clinical manifestations related to diverse embolic, immunologic, and infectious complications. Diagnosing endocarditis requires an astute clinician with excellent physical exam skills and an in-depth knowledge of the pathophysiology. Congratulations! That is it for the infectious disease module. I hope you enjoyed it. It's been a lot of fun going through this all with you. I look forward to talking about this more in class and on the wards.